Okay, well, thank you very, very much indeed for inviting me. I'm absolutely feeling very, very honoured to be invited to your Academic Health Science Network. My name is Geraldine Strathdee. I've been in post, I think it's about 120 days, as the National Clinical Director for Mental Health based in NHS England. And I work with a team of the other 24 National Clinical Directors. I'm also a consultant psychiatrist at a trust in South East London, Oxley's NHS Trust, and I work in the kind of mental health educational department at University College London Partners, so I know a little bit about academic health science networks as well. What I really just wanted to, let me just make sure I'm using this the right way. Here we go. Is there an easy way to do this? I'm sorry to... hang on. So what do I want to talk to you about? It's very much, this is your evening to come together, so I certainly don't want to be taking up your time because networks are about you having the networking opportunity. But what I thought might be useful is just to kind of put in context this superb work you're doing with what's going on at the national level. What I'd like to say to you really is that mental health is definitely, we are on a fantastic journey. We are just at that point nationally when we can tip into mental health being seen as one of probably the most important speciality. In no small part due to fantastic work by people in this room. I mean, utterly acknowledging David's contribution to really kind of getting mental health right up there at the top of the platform. Inside NHS England, so I'm a clinician who has always done clinical work and at the same time done either national or regional policy work, medical management roles. I worked in primary care as a psychiatrist working in primary care for 25 years. So I've always had a number of portfolio roles, and mostly I've gone into organisations, and when I say I'm the mental health person, people kind of duck. This is in policy organisations, and they kind of duck and go off down the corridor. They start fiddling with a BlackBerry. And I suppose what is so different this time, I'm in NHS England, and it's just completely different. I can't honestly cope with the volume of people saying, we really get that mental health thing. Can you help us? And then when I say to them, when you say you really get that mental health thing, what do you mean? And they mean, we know it has a huge impact on the physical health care, the physical conditions of people in primary care and people in kind of specialist care. And then the next question, because what I used to always get was people saying, we get that mental health thing, and by the way, your mental health services are absolute rubbish. They're never there, there's no liaison, they don't come early enough, the CAMs are terrible. That's what it was. It's very different. Among the National Clinical Directors this time, I get, Geraldine, we get that mental health thing, and we get that it is the commonest comorbidity of all our physical care pathways. And can you help us? What should we be doing to raise awareness and training in our own staff, liver, diabetes, cardiac, respiratory, the whole lot? And what should we do? At what point should we be trying to recruit our own therapists? At what point should we be bringing in mental health liaison experts? So it's a very different conversation. So I suppose my ask of you in the mental health and primary care world is, are you ready? When they ask, where do we get the support? Where do we get the learning? Where do we get the education? Can you make that really visible and accessible for people? In NHS England itself, some of you may have already put in a bid. So one of the things to look out for at the minute is there's lots of kind of innovation, people asking for innovation bids in order to kind of be able to move forward, particularly around integration. Integration between primary and secondary care, between physical and mental health, integration with mental health and social care, a lot of kind of focus on that. Strategic networks. Now the networks, I have to say, I am an enormous, I come from kind of a background, you might have gathered, a Northern Irish background of kind of where communities work. You get the power of a whole community lining up. And I think networks is one really seriously good way to achieve change. Across the country, networks are doing things differently. So we've launched 8, including last week, your strategic clinical network. We've launched 8 of the 12 national strategic clinical networks in each of the areas across the country. And each of them are focusing on something a bit different. So I spoke to the people in the northeast today, and they are saying our premature mortality stats are way out. We have to focus. We have got to focus on looking at the causes, physical and psychological, of premature mortality, and focus on that. We've got people in London saying we absolutely need to focus on children's conditions and psychosis because it's a very young population in London and there's a lot of kind of deprivation and therefore a lot of kind of severe mental health problems. People in the southwest, and that was an exciting launch because that was actually in a race course last week. I really enjoyed that one. So down in the race course in Taunton, what they really want to focus on is again safety. They feel they've got, it's a very, very large catchment area, all the way from Bristol right down to Cornwall, and they want to focus on acute, crisis, unplanned care and safety. So I have to say, having come in at the end of 2 fabulous presentations, I think I can see a very, very good niche market for you guys in terms of informing the national strategic picture. What's the relationship between strategic clinical networks, academic health science networks, LEPB networks, existing pharmacy networks, psychology networks? Basically, we need all the brains working together on the case. Our strategic clinical networks feed into the clinical senates, are the kind of powerhouse of some of the decision making. There is no national service framework. I'm not here as the National Clinical Director to tell you what the national service framework is. There isn't one. There are lots of common priorities emerging across the country, but how those get delivered really depends on your local relationships, your local networks, and actually what the kind of needs are for you in your local populations. So I'm partly here as a big ask. One of the things, when people say to me, we really get your mental health thing, one of the next thing that actually a lot of people are saying to me is, and so is that Stephen Fry and Ruby Wax? And do you still do that couch thing? And really, for a speciality that should be about communication, somehow, I think we are just not getting out there the real patient recovery narrative. We're not getting the stories. So people just really genuinely, outside mental health, it's often quite difficult for people to know what we do. So one of my asks is, can you use your really creative brains to work with your service users around co-producing some clinical narrative? If you are delivering best practice and good practice, and that was just fabulous what I heard as I came in, please could you share that? Could you write it up? Say that you're evaluating it, but could you just let other people share your thinking? Because some of that was just, I haven't heard that anywhere else. It would be wonderful to hear that, and very, very good for your network to kind of be acknowledged for what it is. Could you please, because you have a real opportunity at the minute, there is a major national consultation on acute and unplanned care in the NHS. So if you go on the NHS England website, Sir Bruce Keogh, the medical director of the NHS, and Professor Keith Willett, the kind of national director for emergency and acute care, have a consultation, and they're asking, what's the evidence about good models in A&E, in the hospital, avoiding crisis admission? I can tell you, and I think I can say this, in the 25 years I've spent in policy organisations before this year, I have battled and battled and battled and battled every time there's a £2, £3, £4 million review of acute and emergency care to get mental health seen as being actually largely responsible for a lot of people who come to A&E. And I have never managed, despite, as you probably gather, some assertiveness skills, I've never ever managed to get mental health into those acute reviews. This time, we're welcomed with open arms. But the last thing I heard our last speaker say is that, you know, the evidence is there, it's there economically. It may be there, but we still have to keep saying it over and over again. Every time there's a consultation, could you send something in? Even if it's only 5 bullet points, even if it's only making a recommendation to a reference that you know about, that is completely invaluable. So let me just... I think what I will do is I just want to leave you, because it's very much your evening, so I'm going to leave you with these and just go to the one that I really want you to get. Yeah. So what is happening at kind of national level into which your programme is really important? Well, one of the things that every part of NHS England and the whole system is trying to do is to look at how can we support people much earlier in their journey. Can we work with the new Public Health England, which is now based in local government, to look at what can we do around prevention and health promotion, building resilience? What can we do to support our colleagues in primary care, where 80% of mental health happens, to do early identification and actually early intervention? When you're on your trust websites, on your primary care websites, when you're saying for the public to access what services do you have, what is the description you're giving of your services? Do you talk about the access to it? Do you talk about what's offered as an intervention? Do you describe how you're measuring outcomes? Do you describe how service users' experience is kind of feeding into that? We are just about to, and probably in the next 6 to 9 months, launch choice for service users, for public, in mental health. And of course, payment by results is bubbling along in the background. So one of my asks is, could you go back and look at your own websites and see, would somebody making a choice find it very easy to choose your service because it's so clear what evidence-based interventions you're offering and how you're evaluating it? Now, in mental health, we are the great speciality that have led the way in deinstitutionalizing. We've almost forgotten that we did it. You know, when I started in mental health, I was doing things like being part of the group that deinstitutionalized Bexley Hospital, Friern Hospital, several other hospitals. And we went from being a really bed-based institutional speciality to being one that just led the way in working out in the community. In the last, I would say, 2 years, we have begun to see a reverse of that trend. So we've had a 19% increase for the last 2 years in forensic spend on medium secure units, secure units. Every year we are seeing in this country, and we don't really understand this, increase upon increase of detention rates. So we're sectioning more people under the Mental Health Act, and they're going into higher levels of Tier 4 security. I have my own personal views about why that's happening, but I think it's really time to pause, because if we truly believe that as a speciality we can look after people in an evidence-based way, in their own home, in a least restrictive setting, with personalised care, I think we really have to take stock and work out how are we going to reverse this trend that really isn't that healthy. And finally, I think the biggie at the minute is crisis response. And so let me just finish by showing you what's happening around the country, what are the emerging priorities in the context of which, you know, your great evening is. The first thing that's been recognised, and as a long-time advocate of primary care mental health, is the absolute need to support our CCG primary care leaders. In London, we managed to get the funding to train 32 CCG mental health leads across the city, 28 dementia CCG leads. The power in London of having 60 identified advocates, supporters, challenge, but collaborative partners is exponential. London is rocking with its 60 CCG leaders. That's what we want to do across the country. Probably a different curriculum, but that's what we want to do. That's certainly my commitment. Primary care mental health. Internationally, there are several different models of primary care mental health. In this country, at one level, we are still wedded to expecting individual practitioners in short periods of time, over time, to respond to people's needs. 78% of all people who commit suicide have seen their primary care professionals in the month before. That is not me criticising primary care. My younger sister's a GP, I wouldn't dare. But it's basically saying that is not the picture in places like America, Seattle, New Zealand, Australia, Scandinavia, Western Europe, even Hungary, because primary care is supported in a much more federated way to actually address primary care mental health issues. And there is much more of a kind of a stratification approach with different models. We haven't touched the surface of that in this country, although I'm beginning to see amazing innovations as I travel around. I act at the heart of the services with employment support coming in, third sector outreach workers supporting courses, called courses, not treatments, in self-awareness around depression, anger management, supported by public health. Fascinatingly, kind of real population health, primary care innovation around the country, and we want to see more of that. I've talked a little bit about psychosis, just in an absolute nutshell. I think what most of us love to do, and the fact that you're here in an academic place means that you must feel the same way. It's about learning. It's about learning from others. I'm really taken by the industrialization of improvement, the transformation of improvement they made in stroke in this country. 5 years ago, England, to be honest, we were the laughing stock of Europe in the outcomes we were getting for stroke, both in terms of mortality and morbidity. We were second only from the bottom to Portugal, which is an extremely poor country with no real National Health Service. And by virtue of every single clinical team doing a small, targeted, agreed review of a particular important element of care, by virtue of people sharing best practice, by virtue of people having improvement science, stroke in this country is now, we are the second best in Europe in several parts of this country. I honestly believe we have every single one of the same mechanisms that stroke has for psychosis. We just need to make sure that we start doing it across the country. And as you know, we've had the Schizophrenia Commission, we've had the National Audit of Schizophrenia, we've got the Rethink major improvement networks across the country, so we can do it. Acute care pathway I've talked about. Bottom line is, our commissioners are asking us in mental health, can we have a single telephone response crisis helpline? I was in Sunderland some weeks back. They are using a single telephone helpline for a population of 500,000 people across mountains out to the sea, backed up by tele-triage trained call handlers, backed up by specialist clinical mental health team people doing proper telehealth and crisis response, with a 24/7 crisis home treatment model. And the pièce de résistance for any mental health professionals in the room is they use dictaphones, or a BlackBerry. They have a trust BlackBerry. You dictate into it, you press the button, and it goes right into the admin pool, who type it up and put it onto the electronic record, just waiting for you to outcome it on Rio. The clinicians are ecstatic because it's saved between 50 to 60% of their time, and they can spend more time with the patients than having to sit at the computer. Obviously, integrated health you're on, and the two things that if anybody wants to ask questions I can talk about is underpinning absolutely everything with a movement to give you proper information. Brilliant randomized controlled trials and brilliant academic information, backed up by, in partnership with the 29 huge, large national data sets we have in mental health that we hardly ever turn into intelligence. And again, IAPT, I think, has been spectacular in leading the way in this country around outcome measurement. We want to try and build on that and incorporate it into all the other kind of areas of work that we do. So thank you so much for all the hard work you're doing. Please, 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 please share it with everybody else. And thank you again for inviting me.
So we are going to have Dr. Hussey, his presentation before coffee, I understand. Is that correct? Yeah. But if anybody has one or two burning questions at this stage for Geraldine, please feel free to ask. Otherwise, we'll just have any questions? Okay.